All right, and we are live.
All right. Well, welcome to all of you. I'm glad that you made it to this webinar today. My name is Vaughn Bryant with the J Flowers Health Institute. I'm coming to you from our conference room right now, and I'm going to be presenting this webinar on understanding trauma and stressor related disorders. Thank you, TPN, for hosting this today. They have been a reliable source of providing great networking for trusted providers, as well as these webinar events and other kind of training events. I'd encourage all of you to continue to maintain informed or remain informed by checking out their website and seeing the different events that are coming up in the future. So you can go ahead and move on to the next slide. Next slide, please. Ramon is in the background in the control room for me, and he's going to be advancing from slide to slide. I'll tell you a little bit about J Flowers Health Institute. Again, my name is Vaughn Bryant. I'm a mental health specialist here at the J Flowers Health Institute. And at the J Flowers Health Institute, we specialize in providing truly comprehensive health and wellness evaluations for individuals who want to improve the quality of their life. We really do specialize on trying to identify the primary problems a person might be experiencing. We do a full medical, physical, psychological, psychiatric evaluation. And then after we've conducted that comprehensive diagnostic evaluation right here in the greater Houston area, utilizing some of the best providers in the world and some of the best facilities in the world, we're able to give a person what we call a behavioral health MRI and identify some areas where they could focus interventions, whether it be mental health care or physical care, wellness, health, exercise, all of that. So that's us here at the J Flower Health Institute. We have a weekly podcast. I would really encourage you to tune into that, as well as the different resources that we have at our website, which is www.jflowershealth.com. Next slide. You can go on to the next slide as well. So today I'm going to be talking about understanding trauma and stressor related disorders. There's going to be 4 sections to this presentation, this introduction part that we're in right now, as well as 3 others. The next section is going to be about diagnosis. The next section is going to be about really identifying symptoms to target for intervention. And then the final section of the presentation is going to focus on treatment interventions, strategies that you as a provider could employ to help people to recover from trauma and stressor related disorders. So let me begin by defining some terms. I do have 3 references, 3 sources, 3 resources that I'm going to be using throughout this presentation. One of them, and Ramon, if it's possible, could you get my image up in the corner of the screen? I see the TPN Health. I don't know if it's possible that I could see my image of what I'm projecting, just so I could know what the attendees are seeing. Anyway, I'm good with this and we'll continue as it is, but I wanted to hold this document up. I think many of you know this book. It's called the Diagnostic and Statistical Manual of Mental Disorders. This is the 5th edition that came out in 2013. And they did make some changes in terms of where they put the trauma and stress related disorders. They gave an entire section from or for the trauma and stressor related disorders. And I'm actually going to discuss all 4 of those different disorders. So a trauma and stressor related disorder occurs when a person experiences psychological distress following a traumatic event that results in clinically significant impairment in cognition, emotion, or behavior. So there's some key terms right there. One of them is trauma, and we're going to talk about that. Stressor could be any kind of a event that experienced in a person's life that taxes their emotional, psychological resources. Now, when a person experiences a traumatic event, it's an unusual event. It's a catastrophe. It's a major impact in their life. It alters some of the fundamental things that they have come to expect or experience in life. and it has the potential to alter that person in a way that is maladaptive or dysfunctional. I want to say this right off the bat as well, speaking of this, that many people experience traumatic events and they naturally adapt, they naturally process those over a period of days or weeks or months, and they return to a baseline of normal functioning. So not everybody who experiences a traumatic event is going to have a post-traumatic stress disorder. But a person who experiences a traumatic event that alters them and the distress, the distressing symptoms remain for an extended period of time, and it impacts their ability to function in their life, that's when it becomes a traumatic stress disorder when they meet the criteria for the diagnosis. Next slide. So here's a poll question for you. How do you conceptualize post-trauma stress? Do you see it as a permanent mental illness, or do you see it as a present mental injury? And I don't know if we have a poll question bubble up or not. I know I gave Ramon this presentation just last night, so it could be that the poll question may not be popping up as one of those places where you can hit a radio button. But I would like to see some of your responses in the chat bubble there. I'm reading them. Very good. Very good. Okay. It looks like I am in good company here. All right. Thank you very much for your responses. They have overwhelmed me with affirmation. And I want to emphasize this point here is that even though a post-traumatic stress disorder, it is categorized as a mental disorder, it really is an injury, just like a broken arm is an injury. With the right kind of support and rehabilitation, it can return to full functioning. As a matter of fact, I remember one time seeing an x-ray. I think one of my children had a fracture in an arm that they had fractured just a year or two earlier. And when the doctor was showing us the x-ray, they showed us, the doctor said, "This arm's been broken before, hasn't it?" And we said, "Yes, it has." And I said, "How did you know that?" And he pointed to a spot on the bone, the part that wasn't broken. And he said, "You see this increased calcification here on this part of the bone?" I said, "Yeah." He said, "That's what happens when the bone heals itself from a break." And he said, "Actually, the point where he broke it before is stronger than the rest of the bone." And in many ways, that's the potential that a person has when they recover from a post-traumatic stress disorder, that they have this capacity, this ability to recover from this injury in a way that strengthens them with resources, with strategies, with new perspectives, with new insight that they did not have before. Now, I would never suggest that any kind of traumatic event is good for anyone. What I will say, though, is in my extensive work with people who have endured traumatic events and who have done the work in recovery from that traumatic event, many times they will identify ideas or attitudes or concepts or insights that they gained from the growth process that they would say has made them stronger. Next slide, please. I wanted to start with a discussion about the general adaptation syndrome. This may bring some of you back to your introductory psychology course that you may have taken as an undergraduate. And it was a model presented by Hans Selye, and I believe it goes way back even to the 1930s. And what he saw in biological organisms, and particularly human beings, that there's this syndrome or this cycle, this process that occurs when there is some kind of unusual or unique kind of unexpected event. The first stage is alarm. The psyche perceives a threat and the sympathetic response of the autonomic nervous system activates. This is where you get the fight, flight, or freeze. This could be an example. You're driving down the road and you hear the whistle or the horn of a train and you see train tracks approaching. That's the alarm. Second stage is resistance. The mind and body activate to resist the threat. You could be in the middle of listening to a beautiful song, you're singing along, and maybe even carrying on a conversation with someone in the back seat. You hear the train horn, you see the tracks coming, and in an instant, you resist this threat of a train by activating your coordination and pressing on the brake button or the brake pedal of your car. And it stops the car. You come short of the railroad tracks. You see the arm come down, the train passes, and then you let out a big breath of relief and you're in a state of exhaustion. The parasympathetic response of the autonomic nervous system activates, and then it initiates rest and regeneration. This is a natural, normal process, and this is how we deal with these alarming situations in life. Next slide. When a traumatic event occurs, though, it overwhelms our nervous system. Oftentimes, a traumatic event are so extreme that they permanently alter a person's life and their environment. And so the stress maintains at a very high level over an extended period of time. The nervous system is overwhelmed. This natural adaptation process is insufficient to effectively resolve this distress because there is no simple action like pressing on the brake to stop this threat from coming. Sometimes the threat continues to be perceived even after the event occurred, maybe because the threatening situation or the threatening person or the threatening circumstance still exists out there in the environment. So the natural as well as the social or relational environment, it's altered. Another important factor here in understanding the impact that stress has on a person or a traumatic event has on a person is this idea of protective factors. Some people have a very robust protective kind of factors in their life. This could be meaningful and very rewarding relationships, a meaningful work. They could also have effective financial resources, material resources. They have reliable protection or safety from the environment. And when they experience some kind of normal stressor, they're able to use those protective factors to help them endure the crisis and kind of get through that moment. But when a traumatic event occurs and it may deplete these protective factors over an extended period of time, the general adaptation process fails to resolve the stress. And adaptation can be impaired by the loss of those adaptive resources like relationships, safety, security, and provisions. So this is where the defense mechanisms, the strategies, these protective factors, there may be some there at the beginning of this traumatic event, but as they become depleted, the stress becomes more and more impactful in the person's life. Next slide.
Dr. Bryant, before we moved on, I wanted to indicate to you that we have a hand up.
Okay, did you say, do I have a handout?
No, I'm sorry. We have a person hand up. Person has raised their hand.
Oh,
They may want to.
let's hear the question, bring it on.
Okay, so Leonetta, if you want to, you can unmute yourself and ask a question or comment live.
I'm sorry, I raised my hand by mistake. I'm sorry.
Okay, well, Lonetta, we're glad you're here and it was wonderful to hear your voice. Hang in there. So let's continue on talking about the stress of trauma. The general adaptation to a traumatic event can alter a person's baseline thoughts, emotions, and behavior. I think one of the examples that almost everyone can relate to is if you've ever had anything taken out of your car and you left the door unlocked. Maybe your baseline was that you trusted the world and you thought that people would respect your property, but then this event occurs. And so now your baseline of trust of the world is a little bit different. Yes, you still trust the world, hopefully, and you're going to lock your door. That would be a simple example of how there's alterations in these baseline thoughts, emotions, and behaviors. Sometimes those baseline those alterations can actually be very useful. these alterations can be self-protective strategies that serve a meaningful purpose during the crisis event. Now, if these negative alterations in mood and cognition persist beyond their useful function, they definitely can fundamentally change a person's personality, their mood, and reactivity in a dysfunctional way. So, this is how the dysfunctional adaptation to the intense stress of a traumatic experience results in the alteration in a person's mood, cognition, as well as their experience with relationships. Next slide. So now let's look at diagnosis. And for those of you who do have your DSM-5 right there, I've got the big one. This is the big thick one that's about 800 pages or more. You'll find the trauma and stressor related disorders on page number 265 if you want to take a look in there. I'm going to cover some of the overview of each of these, actually 4 different disorders, but I added the adjustment disorder in there because sometimes adjustment disorder really is the diagnosis, even when it looks like a post-traumatic stress disorder. But adjustment disorder is an important one to be familiar with as well. These first 2 disorders, these are disorders, and I think this is one of your quiz questions, so remember this one. These first, at the end of the presentation, if you want to get a CEU, you have to score 70 or better on the CEU quiz. The first 2 are disorders of childhood. The second 2 are ones that can happen with children, but these are most likely what we see in adulthood. Adjustment disorders definitely can happen with children and adults as well, adolescents as well. Next slide. The first one I'm going to talk about is reactive. Go back one slide, I think. Yeah, there you go. These are disorders of early infancy and childhood. This first one is called reactive attachment disorder. And with reactive attachment disorder, what we see here is a pattern of markedly disturbed and developmentally inappropriate attachment behaviors in which a child rarely or minimally turns preferentially to an attachment figure for comfort, support, protection, or nurturance. So again, those of you that can remember and you were well engaged back in your early educational process, undergraduate, graduate work, you may have seen some of the videos. I think it was Bowlby was the one who did so much work on attachment. And there were videos of children as they responded to their parent after seeing I think it was a scary clown or something like that. It was, in modern days, it might be very unethical to do something like that, but it was a study to observe the attachment style. What did the child do when the child saw this clown? It wasn't intended to be scary, but as you know, boo, it's Halloween. If any of y'all saw that Stephen King movie a few years ago, you know that clowns can be very scary. And so the children would be startled or frightened or unsure of this new kind of odd looking clown in the room. And then the child would go to their mother or their father or whoever their primary caregiver was, and they would form this attachment to them. And that would be an example of a secure kind of an attachment. They turned to their caretaker to provide comfort and support. With reactive attachment disorder, we don't see that. The child, it's essentially absent or grossly undeveloped. And the theory is that the child's attachment gets wounded early in infancy because when they did go for support and comfort, it wasn't there, or it was returned with anger, aggression, or abuse. So those are often the historical sequences that we see for the development of a reactive attachment disorder. Next slide. I'm really going to spend most of my discussion talking about post-traumatic stress disorder. I'm only briefly going over these ones from early infancy and childhood. The other one is disinhibited social engagement disorder, and the essential feature is a pattern of behavior that involves culturally inappropriate, overly familiar behavior with relative strangers. this overly familiar behavior, it violates the social boundaries of the culture. Now, some of you that have worked with children or have been in education, early childhood education, or maybe even those of you that are parents out there, you may have even taught your child that concept that I've heard referred to as stranger danger. And there is this sense that children are usually taught that they should not go off with a stranger, they should not leave a parental or a caregiving figure. And with this disinhibited social engagement disorder, that sense of resistance to a stranger, it's not present. It's disinhibited. That stranger danger is disinhibited. So that's disinhibited social engagement disorder. I see there's a couple questions in the Q&A. Ramon, you want to pop that up and let's see what they are? Or have they already been addressed?
One of them was about handouts. Unfortunately, I didn't catch the timing of it. This is probably regarding to disinhibited social engagement disorder. Is that present in psychosocial antisocial individuals?
The disinhibited social engagement disorder?
Okay, actually, they were referring to the previous slide. They were just asking the question, is that present in psychosocial antisocial persons?
You know, that's a really good question. I'm going to talk extensively about personality and personality disorders, and trauma impacts personality. For those of you that have read every single page of this DSM-5, there's a very useful section in the back, and it's called an alternative model for, I'll tell you where it is. I did a presentation with TPN a few months ago about this. It's called the Alternative DSM-5 Model of Personality Disorders. And there's an extensive discussion in there about personality traits. And these personality traits, this alternative model, what it does is it looks for traits and it also evaluates personality functioning. So the question about would this develop into an antisocial type of a personality or maybe an avoidant personality, I think that's a very solid hypothesis that you just made. And that's why it's really important to be able to understand and treat these kind of trauma and stress related disorders, because it could enable a person's developmentally or a developmental trajectory to trend more toward a normal type of adaptation to those kind of early childhood experiences. But that was a lot of words. Short answer was yes. Next slide. Okay, post-traumatic stress disorder. This is the one that most people probably bought their ticket for, and it is a disorder that is most widely diagnosed. And I really have been pleased with some of the movement in the mental health field as well as the general population, and that there's been this destigmatization of mental health care. I worked at a military base for a couple years at one point in my career. And although there still is a resistance and a privacy associated sometimes with people who are experiencing some kind of a post-traumatic stress response to something that they were supposed to be signed up for anyway, like police officers or military, first responders, medical professionals, there definitely is a much greater accepting attitude these days for people to say, hey, you know, I need some help. And there's been a lot of awareness about post-traumatic stress disorder, which has been very good. I also think too, though, that it may have resulted in a lot of people getting diagnosed with post-traumatic stress disorder from their best friend or maybe from their mother-in-law, even though they really didn't meet criteria for the disorder. And we'll talk about that too. It has a lot to do with personality functioning. So first, criteria A for post-traumatic stress disorder is exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. One way would be direct experience of the trauma. You were the victim. Second is witnessing in person the event as it occurred to others. The third is learning the traumatic event occurred to a close family member. Fourth would be experience repeated or extreme exposure to adverse details of the traumatic event. This right here could even be a mental health care provider, that we do get exposed to some adverse, extreme, adverse, repeated uh, exposure to details of trauma. I know when I was working in that program, it was called the Family Advocacy Program on a Army base in Louisiana. I had a very up close exposure to some very traumatic abuse situations with children, with domestic violence. There were deaths involved, murders involved, and it was very stressing. That's for sure. So those would meet criteria A right there. Um, Direct exposure, witnessing in person the event, learning the traumatic event occurred, and experience repeated or extreme exposure. Now, I want to take a moment right here, as I was talking a little bit about military or combat trauma. Uh, I have worked with a lot of veterans, a lot of even active duty, than when I was working on the base. And I saw a few situations where a person had a classic post traumatic stress disorder, but they never got injured. Now, it was interesting. I'm not going to get lost in this conversation right here, but I will say this: sometimes the victim is the perpetrator. Now, that may sound paradoxical, but a person who has a call to duty, let's say it's a deep kind of a spiritual, social kind of calling, they were called to be in some role to be a protector, and they were put into a situation in combat where they had to pull the trigger. That act of pulling a trigger was traumatic to them in terms of it resulted in this deep psychic injury. So that's something else that I've seen along the line, that even a person that may not have experienced this actual serious injury, there was this deep psychological injury of something that they did, something they perpetrated. Let's go to the next slide. Criteria B is where we start seeing the symptoms. So they must have had the traumatic exposure first. Then we start seeing these symptoms that begin to emerge beginning after the traumatic event occurred. Recurrent involuntary and intrusive distressing memories. These are what we call this whole section of 5 symptoms here are the intrusion symptoms. They have to have one or more of these to meet criteria B. Distressing dreams. Number 3 is dissociative reactions, in which the individual feels or acts as if the traumatic events were reoccurring. Intense, prolonged psychological distress at exposure to the internal or external cues that symbolize the traumatic event. This is what people refer to as triggers. And number 5, marked physiological reactions to internal or external cues. You'll see this sometimes when a person does get triggered, they'll call it a panic attack. They'll start trembling, their breath will become short. The sympathetic nervous system is activated and they're in that fight, flight, freeze response. Next slide. Criteria C, it includes what are the avoidance symptoms: persistent avoidance of stimuli associated with the traumatic event beginning after the traumatic event occurred, as evidenced by one or both of the following: avoidance of efforts or avoidance or efforts to avoid distressing memories about that event or that were closely associated with the event, or number 2, avoidance of or efforts to avoid external reminders that arouse those distressing memories, thoughts, or feelings. Now, I'll say this, that many times I see substance use as the primary method of avoidance. So there's a high co-occurrence between post-traumatic stress disorder and substance use disorder because it is a very convenient avoidance of that distress or those internal stimuli. Next slide. Criteria D are negative alterations in cognition and mood. As I mentioned earlier, after the traumatic event, these fundamental beliefs and reactions and attitudes about life and even core aspects of personality can be altered. And these alterations remain. They really seem to take the form of some kind of protective purpose, which may be functional in the first few days, weeks, or months after the event, but then they become dysfunctional once the threat has been resolved and is no longer present. So some examples of these negative alterations in cognition: inability to remember an important aspect of the event. Now, next I'm going to talk about acute stress disorder. Acute stress disorder is when the distress, or when the traumatic event or the stressful situation is still happening. And we see sometimes when people are overwhelmed with stress, they do become very forgetful. Now, one of the unfortunate things is sometimes people will end up going to see some kind of prescriber who they'll tell some of these symptoms, and the prescriber will uh, prescribe them an amphetamine, thinking they have ADD, or the prescriber will prescribe them a benzodiazepine, thinking that they have anxiety. Both of those drugs, not only are they not going to help someone with post-traumatic stress disorder, but they really do, they are very dangerous, and they can seriously worsen their condition and prolong their distress. As a matter of fact, I printed a bulletin from the World Health Organization that was published back in 2013. And here's just a couple sentences. They said this: primary healthcare staff are also warned against certain popular treatments. This is a World Health Organization release guidance on mental health care after trauma. So they're really talking about treatment for post-traumatic stress disorder here. They said primary health care staff are also warned against certain popular treatments. For example, benzodiazepines, which are anti-anxiety drugs, should not be offered to reduce acute traumatic stress symptoms or sleep problems in the first month after a potentially traumatic event. In addition, referral for advanced treatment such as cognitive behavioral therapy or a new technique called eye movement desensitization reprocessing therapy should be considered for people suffering from PTSD. So let's go on to the next slide. Criteria E are these alterations in arousal and reactivity. And again, this has to do with the sympathetic response to situations that really may not be threatening, but it evokes that kind of fight, flight, freeze type of a response. You see this with irritable behavior or angry outbursts. That would be the fight mode. Reckless or self-destructive behavior, hypervigilance, exaggerated startle response, problems with concentration, and sleep disturbance. Again, you're beginning to see some similarity with ADD or anxiety. That's why it's so important for a comprehensive diagnostic evaluation. Next slide. F is that the duration of the disturbance is more than 1 month. The disturbance causes clinically significant, G is that the disturbance causes clinically significant impairment in social, occupational, or other important areas of functioning, and the disturbance is not attributable to the physiological effects of a substance. Next disorder, next slide, is acute stress disorder. And I'm not really going to spend a lot of time on this. I want to get into the treatment component of this presentation as fast as I can, spend the rest of the time doing that. But acute stress disorder, it's very similar to post-traumatic stress disorder. The symptom presentation looks a lot like it. And the difference, though, is that the acute stress disorder is right in the moment of the traumatic event. If the traumatic event has come and gone, then it becomes post-traumatic stress disorder. I did a presentation about 6 months ago talking about, really it was about technology-assisted services, what many of you healthcare providers have been doing with telehealth. And it was at the beginning of the COVID pandemic crisis. And one of the things I noticed that so many people were in this acute state of stress. And I spent a lot of time talking about acute stress disorder. And the thing about it is that there's no end in sight. The pandemic is with us. It's everywhere. So many people right now are in a state of acute stress disorder about this historic event called the pandemic. It has not ended yet. So we're in this acute state. So it's not a post-trauma state. I saw there was a question. Ramon, did you want to introduce that question?
Absolutely. Someone is asking, with respect to dissociative features, is it possible that an infant exposed to severe neglect or lack of attachment can develop a full dissociative disorder pre-verbal that would significantly interfere with the person's ability to ever process or resolve the manifestations of the trauma?
I think that's quite possible. It would be very hard to assess a dissociative identity disorder in an infant. As a matter of fact, I think to look in the, I got the DSM. I'm going to take a moment here to do it. But some of the disorders they have an age requirement. So let's take a look here. I will say, though, it is very possible that a child learns dissociative reactions very early. $291, that's where you'll find it in your textbook. That's such a good question. I have to get the answer. Yeah, it does not have an age limit here on dissociative identity disorder. So again, answer is yes. That was a very insightful question, very well informed. Next slide. So as I said, acute stress disorder, we're in the middle of the stress and it's impacting functioning. These symptoms, 9 or more of the following symptoms occur. So we'll look at these next slide, please. We've got the intrusive symptoms, recurrent involuntary intrusive distressing memories, distressing dreams, dissociative reactions, intense prolonged psychological distress. Next slide. Inability to experience positive emotion. Oh my goodness, that has been present. I don't know if you've experienced it, but I think people are having a hard time feeling good about things these days with this acute stress that we're in. Another term, again, we see this with depression, it's called anhedonia. You'll see there's a overlap of many of these post-traumatic stress disorder or acute stress disorder. There's definitely a mood component to it. Next slide. Dissociative symptoms, an altered sense of reality of one's surroundings, inability to remember an important aspect of the traumatic event. Oh my goodness, just the other day, I was talking to someone and I literally referred to it as the old days. And the old days, it was 2019. But there's this sense of disconnect. Some examples in acute stress disorder of these dissociative type experiences is people have a hard time remembering stuff. They may forget where they parked their car. All right, let's keep on advancing to the next section. Keep going. Okay, assessment of predominant symptoms. I really wanted to talk about differential diagnosis as well as getting your head oriented correctly around assessment and treatment of trauma. Trauma resolution, it's focused on the present, not the past. There's nothing you can do to improve your past. The focus of treatment is on the present dysfunction in thought, emotion, and behavior. There is something that we can do to improve the present, and helping a person change the way they react to their present can create hope for a better future. Next slide. The trauma assessment. Again, go through the criteria. Too often I will be in a clinical meeting, not here at the J. Flowers Health Institute. We are very thorough and comprehensive, but I've been in situations, I've supervised interns for a long, long time. And sometimes there's a real sharp, smart one who, after just hearing 2 minutes of a case presentation, they know the diagnosis, which great, hats off to you, but that's not always the most reliable. Sometimes people say, oh yeah, that's PTSD. Well, have you evaluated for personality disorder? Have you evaluated for a mood disorder? And let's really look a little deeper and take a look. So the first thing is criteria A. You know, sometimes people come in for assessment or treatment and they say that they've been traumatized. And when they explain what was traumatic, it really doesn't meet criteria A. And in that event, we're looking at something a little different. It could be an adjustment disorder, or it could even be a personality disorder. Serious injury, of course, physical injury, having a car wreck that could have been fatal, that would be serious injury, even if there was no bumps or scratches. Psychological injury, let's go to the next slide. I'm going to talk about this a little more extensively, but this is a subjective term here. And sometimes the way that we interpret an event as trauma, it doesn't meet criteria A, but by treating it in the same kind of significance or severity of criteria A, I think it can actually impair a person's recovery. It might even enable their dysfunction. And some of you may have seen situations where, people have refused to do certain things because they say, well, it activates my, it's a trigger. And that manipulativeness is a way to avoid having to do something that's really significantly important and useful for their life. So it's important to take a look at their personality functioning. Again, that section in the back of the DSM has a very useful, it's called the level of personality functioning scale, and it helps you to identify if the person's personality is functioning effectively or are they impaired in personality functioning. One of the symptoms of or one of the disordered personality traits listed in there is emotional lability, and this is the instability of emotional experiences and mood. Emotions that are easily aroused, intense, and or out of proportion to events and circumstances. When I go to Chick-fil-A and I order barbecue sauce, Polynesian sauce, and Chick-fil-A sauce, one of each, and I get my bag and all they have is Chick-fil-A sauce, and I freak out because it's traumatizing to me because I didn't get the sauces I want, that's not a traumatic stress response. That is a emotion dysregulation problem. And the problem there really isn't processing the event, but it's about learning to have a more effective way of conceptualizing discouraging disappointments in life. Evaluate for personality function. See that, particularly if the response to the event is exaggerated, if it's not in proportion to the circumstance. Next slide. Assess the symptoms. I've talked pretty extensively about that, but here's a little bit about differential diagnoses. The alteration in mood. It's important to understand that depression and anxiety roller coaster of the sympathetic arousal of post-traumatic stress disorder. It's not an anxiety disorder, and it's not a depressive disorder. When a person is anxious for 45 minutes and then depressed for a couple hours, that does not meet criteria for a mood disorder. A manic episode is 5 days. A major depressive episode is 2 weeks. So when we have this roller coaster that goes up and down over a few hours, these are not mood disorders. These are reactive, these negative alterations in mood. Treating the symptom will not cure the cause. So treating anxiety or depression is not going to cure the post-traumatic stress disorder, but if you cure the cause, you resolve the symptom. Next slide. Let's talk about that a little bit more. The altered state, yeah, I covered that already. I wanted to re-emphasize it. Even when I proofread my slides, I said, well, I just put that on the previous slide, but it's worth saying again. The depression and anxiety roller coaster of sympathetic arousal is not an anxiety disorder and a depressive disorder. It is a symptom of the post-traumatic stress disorder. I am rarely going to diagnose somebody if I've diagnosed someone with a post-traumatic stress disorder, I'm rarely going to diagnose them with an anxiety disorder and a depressive disorder, because I'm going to see those mood fluctuations as symptoms of the post-traumatic stress disorder. And I'm going to treat the post-traumatic stress disorder, and by resolving the post-traumatic stress disorder, oftentimes you see resolution of the alteration in mood. Explore factors that could contribute to the manifestation of the symptoms. These could be personality disorder, it could be substance use disorder. Okay, well, let's accelerate. We still have about 12 more minutes. Now we're in the part that I really wanted to talk about, because this is where the magic happens right here. And again, I polled y'all at the beginning, And most of you, what you said was music to my ears, and that you see post-traumatic stress disorder as a mental injury, not as some kind of permanent mental illness. It is a maladaptive response to a unexpected traumatic experience, and being able to help the client to functionally adapt and adaptively process that information can lead toward resolution. I saw a question pop up. You want to give that one to me, Ron?
Sure, sure thing. Someone is asking, could you expound on the statement that treating a person without criteria A with trauma interventions can make things worse?
Well, I didn't mean to say that. I think treating someone for trauma resolutions, even if they don't have PTSD, it's not going to make it worse. It's probably going to be very helpful to them. What I did say, though, is that sometimes we as therapists can be enablers. Let's say that, a person comes into me and they say that they have this, traumatic abusive situation going on with their mother. And I say, okay, tell me more about it. And they say, well, yeah, my mother never gives me what I want. She's not helpful to me. She doesn't do the things that I need from her. And it turns out that this person is 35 years old living at home, and that person's experience of being neglected is really a it's an inappropriate expectation of what a mother of a 35-year-old son should be. I don't know if that example was good enough, but sometimes when we are uh, I'll just leave it. I'll leave it at that. That's my example. I don't believe that it would be harmful to treat someone with trauma resolution strategies if they've never experienced criteria A. What I am saying is be thorough in your evaluation of their personality functioning and in their emotional reactivity. Because one of the things that I've seen, particularly in cases with impaired personality functioning, like maybe a histrionic personality disorder or a borderline personality disorder, is that there's a tendency to interpret normal life events as being catastrophic. And the problem isn't that the normal life event occurred. The problem is that they interpreted that normal life event as catastrophic. So for them to be able to reorganize their thoughts and their reactivity to normal life events would be more functional and more helpful than uh, helping them to somehow deal with the stress of being overwhelmed with something that's normal. So anyway, great question, complex answer, and I am in fifth gear right now trying to get through the rest of these slides. So I'm going to keep going. Guidelines for the therapist. Establish a validating and empathic therapeutic stance. In light of that last question, I would never diminish the significance of any event that a person might experience. If, say, I was interviewing a person who it was obvious to me that they were having a exaggerated kind of emotionally dysregulated response to a normal life event, the best thing that we can do as therapists is to validate that distress and really establish that therapeutic relationship. Any of you that have worked with clients before that may have had a borderline personality disorder, it's really important to establish that therapeutic alliance. And then you very strategically begin to challenge some of these emotionally exaggerated responses. So empathy and validation is essential. Validate the client's experience. Feelings are real, but they're not always facts. Now, the example to that could be is that I may feel rejected because I didn't get what I wanted emotionally from this person that I'm trying to reach out to, but it doesn't mean that I am rejected. There could be so many other factors involved. And so many times I might feel unlovable, but it doesn't mean that I am unlovable. So validate the client's experience. Their feelings are real, but they're not always facts. Engender hope by being optimistic and motivate the client to become self-aware of their thoughts, feelings, and behaviors. Move clients away from processing misery and toward resolution of impairment. Next slide, please. Cure the cause. In a client with PTSD, the traumatic event gets interpreted in a maladaptive way. And that interpretation, it continues to reactivate the sympathetic nervous response. That's the distress that's characteristic of the post-traumatic stress. The maladaptive interpretation is the cause. The distress is the symptom, but the maladaptive interpretation is the cause. So let's say somebody was abused by a particular gender, and then they come out of that experience with this belief that those people of that gender are dangerous. And in reality, there may be some dangerous people in that entire population of that gender, but that gender is not dangerous. It was that person who was who was dangerous. So it's important to help the client to come to this understanding of how maybe in their response to try to protect themselves, they may have exaggerated some kind of cognition and their emotional response was maladaptive. Treatment of the symptoms can be useful, but it doesn't cure the cause. And I read that from the bulletin, the World Health Organization, about benzodiazepines. Adaptive information processing reprocesses the maladaptive interpretations associated with the traumatic experience. Adaptive information processing is what is at the core of EMDR therapy. I'm going to talk about two types of therapy that are very effective in working with post-traumatic stress disorder. And these are also the two that are recommended by the World Health Organization. Actually, they said cognitive behavioral therapy, but dialectical behavior therapy is a form of cognitive behavioral therapy. Let's look at the next slide and we'll begin talking about dialectical behavior therapy. It's a cognitive behavior therapy that involves counseling, skills training, and behavior coaching designed to help clients accept their current life circumstance with a determination to make meaningful changes in their personality, thoughts, and behaviors to experience a life worth living. To be dialectical is to integrate or synthesize the seemingly opposite strategies of acceptance and change. Next slide. There's 5 modes of practice in dialectical behavior therapy. There's the skills training, which enhances the client's capabilities. It equips them. I did bring a copy of the DBT Skills Manual by Marshall Linehan, or actually it's called DBT Skills Training Handouts and Worksheets. It is filled with hundreds of very useful practical strategies that the client can learn to regulate their emotion, to enhance their communication skills, problem solving skills, and to tolerate distress. I'll just show you this on the next slide. You'll see this, but that's one of the main categories of skills training is distress tolerance. Individual therapy in DBT is designed to help problem solve and improve clients' motivation. The in-the-moment coaching is a very useful, very accessible component of DBT where the client can reach out to the therapist and get some in-the-moment coaching, either by text message or phone. Case management is about really enhancing the environment. And then the DBT consultation team is the therapist working with other DBT therapists to maintain fidelity to the model. Next slide, please. So you'll see these are the 4 groups of skills that are taught in skills training. Distress tolerance is extremely useful for a person with a post-traumatic stress disorder. Also, emotion regulation. These skills are so effective at helping them to downregulate their physiological reactivity to stressful situations. Now, the final section here, I'm going to talk about EMDR. Next slide, please. And this right here is the cover of Francine Shapiro's book, Eye Movement Desensitization and Reprocessing Therapy. This is edition 3, which just came out about 2 years ago, right before Francine Shapiro passed away. She really developed this 40 years ago, 30, 40 years ago. And it was a serendipitous discovery where she noticed that she was processing something from her own life and her eyes started moving back and forth and it seemed to dissipate the distress. Her being the scientist that she was a psychologist, behavioral scientist. She went on over the next 3 decades doing comprehensive scientific research on the effectiveness of rapid eye movement and also some of the concepts from behavioral therapy like desensitization, systematic desensitization. And what the desensitization does is it facilitates the reprocessing of this unconscious material and it activates the adaptive information processing system. Next slide. This is the final slide here. I'm going to mention to you briefly the 8-phase protocol of EMDR. Uh, Both DBT and EMDR are techniques, they're strategies that could be learned through probably 30 to 40 hours of continuing education with some supervision, maybe for another 6 months or so. And if you're working with clients who have a post-traumatic stress disorder, I would strongly encourage you to be informed in both of these models. Phase one is a client history. It's kind of like the psychosocial assessment. That's where you're really looking to see what was the traumatic event, what are the symptoms that are presenting. Phase two is preparation, which is resourcing the client, really helping them with some emotion regulation, distress tolerance, mindfulness type skills to be able to seize control of their thoughts. Third is the assessment of the target for desensitization. Now, phase one usually happens in about a 90-minute session. Phase two, it could be done in one hour session, but it might persist for a couple sessions. Now, phase 3, 4, 5, 6, and 7 are done in the subsequent EMDR sessions. Usually they're about 90 minutes long, and it begins with an assessment of the target for desensitization, which is what do you want to work on? What traumatic memory, what distressing thought do you want to work on? And then we'll isolate that down to a short phrase that really represents this negative cognition that they've integrated into their belief. Like they may have been the victim of a rape and now they're thinking it's my fault. And that is what's so distressing, that they're holding on to this shame, this guilt, thinking it's my fault. That's where in phase 4, we desensitize that phrase, it's my fault, with sets of bilateral eye movements. Phase 5 is the installation of a positive cognition, which would be usually the deconstruction of it's my fault. And that would be, in this particular case, I would like to spend a little more time really developing the appropriate phrase with the client, but you identify an affirmation that empowers them and it puts them back in a position of safety and security. Something like, I am safe. That would be a perfect example of a positive cognition for installation. And then phase 6 is the body scan, phase 7 is closure, and phase 8 is reevaluation. All right, well, when I put the presentation together, or I was beginning to put it together, I thought I want to get about 20 slides. I think I ended up with about 50 of them, and I was able to get through most all of it. I really appreciate your joining us today. I noticed there were many participants out there. I hope that it was helpful, and I really want to encourage you to pursue enhanced competence in DBT skills as well as EMDR. I think that will really help you treating people with post-traumatic stress disorder. Thank you. That concludes our webinar.
Thank you, Dr. Bryant, and thank you to all our attendees. We're going to have to go ahead and close things down now, but I appreciate everyone's attendance. Additionally, I just want to point out that we will be sending a post-session email. It's going to go out 24 hours after this session ends, which will be basically 24 hours from now, which will include links to your evaluation. So keep an eye open on your inbox for that. So thanks again to Dr. Vaughn, Bryant, everybody being here. We'll go ahead and close the session out now. Everyone enjoy the rest of your day, please, and have a great weekend.